Hi, I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to Staten Island and the entire tri-state community. We're going to be talking about stroke. As a neurologist and chief of neurology at a local hospital, Richmond University Medical Center, we have a stroke unit, and we take care of stroke patients. Stroke, there are 800,000 patients in the United States per year who have strokes. It is the #1 cause of disability in the world. And it's something that affects all of us just by thinking about all the people that we know have had a stroke, family members, friends. And it is one of the greatest fears that we have. As a neurologist, I went into neurology thinking that the brain is the one part of you that you really can't replace. You know, the kidney doctors will laugh. I can say we can put a new kidney in. You know, heart people, we can put a new heart in. But when there's a brain injury, people become different. Personalities change, speech changes, memory changes. And that's really why we're out here to try to prevent and reduce stroke, both from what's called primary prevention, figuring out how to prevent it from happening in the first place, to secondary prevention. We've come a long way in stroke, and I have an exceptional guest. Our show has been on for over 8 years, and he is one of the finest, brightest people in his field, a really dynamic person who's really as much cutting edge in educating people, and on a national level being able to teach and really bring some of the newest techniques that we have. So it's my pleasure to introduce Dr. Jeffrey Farkas, someone I've known for many years. He's the chief of neurointerventional radiology, which will help us define in a few seconds, at Richmond University Medical Center. And we're going to talk about stroke in a little bit of a different way. When I was trained in the city, in Manhattan, and the whole goal was whether you gave someone 1 aspirin, 2 aspirin, 4 aspirin, that's all we had really at our disposal. And we've had a lot of other treatments, mostly to prevent a second stroke. You're the guy, your team, and you specifically, are the guys we call in if people have had a large, sizable size stroke, and we'll talk about what that means in a few minutes. And you're the guy who pulls out the bad stuff and gets people back to close to normal or better. So I want to thank you so much for coming. And since this is a topic that's so near and dear to me, I'm talking a little bit. But maybe tell us, what's a neurointerventional radiologist?
Well, first of all, thank you for that amazing introduction. I mean, you know, going to work on a daily basis with you is a real pleasure.
Oh, and thank you.
What I do in simple words is I'm a plumber for the brain. You know, when the blood vessels don't deliver the blood supply to the brain, we restore it. And if it's leaking and causing bleeding in the brain, we stop that. And we do it all through using special catheter techniques. And so a neurointerventional radiologist or an endovascular neurosurgeon or a interventional neurologist are all coming from different specialties to do the same thing, where you use these special techniques using X-ray guidance and small little catheters, which are essentially plastic tubes, and bringing them up into the brain without going through the skull, by going through the blood vessels. I like to describe the blood vessels of the body like the subway system of New York City. You can get from one place to another without a problem as long as you know how to get there, and you can just get there. So my colleagues in cardiology work on the heart, we work on the brain.
So this is similar, so say our viewers know about all kinds of procedures to open up arteries, stents and angioplasty, things that make arteries open, things that are closed, prevent heart attacks, reduce the size of heart attacks. Is that the same thing that we're doing here?
We use many of the same tools. Cardiology is more about opening up blood vessels to the heart that get narrowed, or what we call stenosis. We do that too. We try to open up the blood flow in the brain when a blood clot forms inside the blood vessel and then travels to the brain. It's what we call an embolus. And that's really the major cause of stroke. And when that happens, you know, everything is time dependent. You know, they say, you know, time is brain. We all know every minute counts. You know, you lose about 1.9 million brain cells every minute when the blood is not getting to the brain and you're not getting enough oxygen. And so every second counts. And what we're doing at Richmond University is we're screening and working together with your team to make sure that every stroke patient gets the opportunity to get the blood vessel open as fast as possible.
So tell us about your interest in stroke. How did a radiologist become interested in stroke?
It's the other way around. When I was a resident in Staten Island University Hospital, you were an attending. I don't know if you remember this. And my wife's grandmother, who's been a Staten Island resident all her life, essentially had a stroke in front of us. We rushed her to the hospital, and then it was 1994, before TPA, which is the clot-busting medication, developed. And we just really, the whole treatment of stroke was really watching the patient, examining the patient, and preventing complications, but not addressing the issue, which is really the blood clot that went to the blood vessel and stopped the blood supply. So I looked towards training to find a way to go into the same thing that the cardiologists were doing in the heart in those days, we weren't doing in the brain. And so subsequently, I found the training program, and I aimed for it. And the only opportunity was you had to become a neuroradiologist first. So I became a neuroradiologist, and I trained at Massachusetts General Hospital. And then when I went up there, we started investigating the uses of catheters and using tiny amounts of clot-busting medications directly in the blood vessel. And we had patients who had deadly strokes. I mean, they were unable to move, they were unable to talk. And then you do this procedure, and they open the blood vessel, and wow, they return back to life. And what an amazing thing. And it took us from 1996 to 2015 to perfect the techniques. And in 2015, you know, the trials came out, the major trials that proved that this is the best thing that you can do for a stroke patient. So if you're having a stroke and you're having an issue, get to the hospital so you can get the opportunity to get better. It is no longer a death sentence, and it is no longer a requirement that you end up stay paralyzed. You can actually get better from stroke, and we can make 50% of patients a lot better if we do these procedures in a timely fashion.
So let's go back to stroke again. I mean, the idea is that we want people to come in quickly. Your techniques, you don't do this on every patient. No. So how do you decide? How do I decide? How does the hospital decide who would be a candidate? And again, patients should not stay home and say, well, I'm going to decide whether this might help me or not. It's basically come to the hospital.
Come to the hospital, the emergency room, and you are part of the advanced team. You know this. We take them first to CAT scan, and we image their brain, because we don't know if the type of stroke that they're having is a bleeding type stroke or what we call an ischemic stroke, where the blood flow isn't getting there. So the CAT scan can tell us if there's bleeding. And then we just give an IV into the IV. We give them some medicine, which we call a dye, but it's really a medication. And it shows up on the CAT scan in the blood vessels. And so we basically have an AI computer that looks at the machine and plots out like a Google Maps if the blood vessels are open or not. And if they're not, then we go to work.
And so when someone goes to the hospital with a stroke, in what time frame will we know whether your team would need to come in and try to open up the artery?
Well, we want to know as soon as possible, so we're constantly, you know, looking at the scans and making sure the team gets to see the patients as fast as possible. This is not the type of thing that you're going to wait in the waiting room for 3 hours and then get seen. This is the type of thing that they're going to bring you in. And, you know, even if you say, I think I'm having a stroke, you should be seen right away. But the time frame that we can treat patients is increasing. We started off with the studies that said 6 hours you can treat a patient. Then we started with the further studies that went to 12 hours. Now we're at 24 hours, and we're using imaging. We're looking at the brain to see how much damage there is compared to how much brain there is to save. So some patients, we can save all their brain if the damage isn't too much. With some patients, it can save 50% of their brain cells. And now there are even studies that saying that we can treat patients with advanced changes or damages, and they still do better. So we can save even the ones that are even having really, really bad luck.
I think that's the concept that patients sometimes don't realize, or even doctors don't realize, that it's not an all or nothing phenomenon.
Right.
That you could have a trickle of blood flow, that the cells are still being preserved, but then if you open it up, then wow, you're going to do great. So that's another. We're able with our radiography, with all the CAT scans something called the CT perfusion scan, CT angiograms, to see whether whether someone would be a candidate for it.
Yeah.
So the term that we use in the hospital, I think everyone needs to have this defined a little bit, is large vessel occlusion. They use the term LVO. Because there are a number of patients where no matter what you find on clinical exam, sometimes it just turns out it's a small blood vessel like the size of your hair, and it causes an area of the brain not to get enough oxygen and blood supply, and it dies. And people could be left with significant deficits, but usually it's smaller because it's a smaller part of the brain. You guys usually come in under something called LVOs.
Yeah.
So maybe define that a little bit and what people have to think about, and how do we know it's an LVO?
So that's a great question. We don't treat every stroke. We treat the big ones, the ones that are going to kill you if you don't get treatment, the ones that are going to disable you and keep you from seeing your family, and or putting you in a nursing home because you can't take care of yourself. And what we're talking about with LVOs, or large vessel occlusions, are the bigger blood vessels in the brain. You know, what we call big in a blood vessel in the brain is 3 millimeters. A dime is actually 17 millimeters in diameter. So we're talking about pretty small blood vessels. But those are the ones we go after where we can see where the clot is and pull it out. If we can't see the clot on the angiographic images, on the pictures that we do, there's no point in doing the procedure. You can have strokes that occur in what we call medium-sized vessels, and we're now going to attack those. So the 3 millimeter vessels, which the main trunk, the middle cerebral artery, and the branches of the middle cerebral artery, which are the main suppliers to your brain, we've been doing that for a while. Now we're going further out into the tree, to the top, or where the leaves are a little bit higher, and we're attacking some of those. And so I think as time goes on, we have treatments for the things that we weren't treating before. And there's a recent study that even going back to the old days where you can give TPA, which is that medicine that we talked about.
Tell us about TPA. We can both
Tissue
talk about it.
plasminogen activator. It's a very powerful clot-busting medication, and we can give that into the blood vessel after a thrombectomy, after we pull the main clot out, and it opens up the smaller blood vessels, so you can get a better outcome for patients. And that's what we're striving for, the best outcome for every single patient.
And over time, things have improved. I mean, we use the term TPA. Our hospital recently went over to something called TNK, which is a newer form, but a little cleaner in medicine, a little bit easier to use. So again, as cutting edge as we get. Interestingly enough, the technology has improved, the same way as it had in cardiology. The reason that patients didn't do well, or maybe we didn't know that they were going to do well in the 1990s and early 2000s, is because the advances in catheters, I mean, sometimes you make it sound simple with just the wire or just the plastic tube, have really changed. Because if you think about it, if you have a plumbing issue at home, sometimes if you just keep on poking at it, things go further down and clog up more things and cause a bigger problem. And that's what seemed to happen early on. So maybe tell us a little bit about what kind of newer techniques we have that are out there that prevent people from getting worse, and why now we're seeing the benefit and we weren't seeing the benefit maybe 15 years ago.
Right. I think that's a great question. You know, we have two components to this. One is the experience of the interventionalist. You know, if you have a tough problem, the more you've done this, the better the outcome's going to be. And so we've spent years, I've spent years perfecting these types of treatments. And so the experience of the interventionalists have improved. We're doing this much more frequently now. And now we have a multitude of companies that have created devices that allow us to do this even better. Because we've proven, in 2015, we proved that this is a great treatment. At that point, we had one catheter and one stent retriever, which are the devices that we use to go and open the artery. Now there are dozens. And so each one has a slight difference, and if you pick the right tool, you get the right result. So I think that's really been incredibly important, and how the imaging has gotten so much better, so that we have the tools to evaluate the patient before the procedure. We have the tools inside the procedure, and then we have the tools to manage the patients after the procedure. So I think everything has gotten so much better. In fact, Stroke used to be the 3rd most common cause of death in the United States. We've made it the 6th most common cause. We've pushed it back. So we've made a tremendous amount of improvements in the care of stroke, but there's a lot more to go. Not everyone has access to these types of procedures in the United States. If you live in a rural area, you might be hours away. So we have to expand, the neurointerventionists have to expand our reach to every hospital that can utilize this kind of equipment to give our patients the best outcomes.
And I think it's so interesting. There's some experimental models that are around the country, even in New York, where they have an ambulance that actually has a CAT scan machine on the ambulance.
Yeah, we have a couple of those just to speed things up. And so they come to the house and they put you in the scanner and they go via telemedicine to the radiologist to see, and the examination, they give you the TPA or the TNK, the clot-busting medication, they bring you in faster. Right. That can save 15, 20, 30, 35 minutes, and that's an important period.
As we said, time is brain.
Yeah.
Those brain cells, when we think about, if there's not enough oxygen or blood getting into these areas, these cells die. I mean,
right.
they're irretrievable.
That's why it's so important for patients to realize, or for family members who see the patients having the stroke, don't go to sleep. Don't go to your regular doctor. Don't make an appointment the next day. Go to the hospital. It sounds scary, but it really could make the difference between whether you can walk out or not.
Let's go, I just want to go back to one technique thing that I always think is so interesting we talk about. We learned a lot from our cardiology colleagues.
Yes.
I think about neurologists sometimes being 15, 20 years behind, with different kinds of surgeries that have been done. And now neurology used to be a field where we would be very, very smart sometimes.
Very smart.
And think about things a lot, but really not be able to help too many people. Neurology right now in the field of multiple sclerosis, seizures, and clearly with you and with what we're doing with stroke, has changed dramatically. That so many of my neurology residents and people who are going through training all want to get in this cutting-edge field.
Yeah.
Tell us a little bit about the retriever, in a sense. When you poke a hole in these clots, what I think has made some of the big differences is that we don't just poke it, we actually suck it up at the end.
Yeah,
so I think people would like to hear exactly how you prevent all these major problems.
Oh, so I mean, I like to describe it in very simplistic terms. So we have one device, which is what we call an aspiration device or a sucking catheter. You know, it's almost like if you take a straw and you put it into ice cream, and then you pull out the straw, at the tip of your straw, you'll have ice cream inside the straw. And if the straw is big enough and it's the size of the cup that you're trying to get the ice cream out, you can get a lot of that ice cream out. So, and if you attach suction to it. So that's really one of the simple techniques that we use. We basically bring the catheter to the clot and we push it onto the clot with suction. And then when we pull it out, it's really inside the straw, or it's been sucked out. And the other one is, you know, the old you know, I would say the Chinese fingers, where it grabs your finger, and if you pull on it, it sort of pulls on your finger.
Yes, I know.
You know those? So that's what the other device is really. It's a metal tube on a stick, on a wire, and when it's deployed, it pops open, and now it sits in a clot, and then when you start pulling on it, it shrinks and grabs onto the clot and holds onto it as you're pulling it out of the body. So those two devices have made a huge difference in the treatment of ischemic stroke.
And I think that's so important to say that how technology has gotten better. I mean, you make it sound simple, but there's some
It's gotten a lot more simple.
And they're real tiny, these things too, these catheters, but it really makes people's lives very much different. So let's talk about stroke as a whole. There are different kinds of stroke, and even in our center, there are still a number of patients that have a fancy word called cryptogenic stroke. We never know. I mean, idiopathic, which is sometimes a funny term that the doctors are idiots. We just don't know the answer as to what caused the stroke. In those patients, we're seeing a lot of heart irregularities causing it. In our hospital, we're actually putting in a little detective device called a loop from the cardiologist to see that these people don't have this irregular heartbeat called atrial fibrillation. So there are things that we're looking for in stroke that are so different. The other thing you talked about, small vessel disease, little tiny vessels, medium vessel disease, large vessel disease. Sometimes different arteries get affected. So back to the clinical aspect of stroke. I mean, you or I could both say this, and you're my guest. I'll let you talk about it. What symptoms? The first thing that you said that I think is so right on point is don't go to sleep.
Yeah.
If you have numbness in your face or slurred speech or weakness in your arm, going to sleep is the absolute worst thing you could do.
So, there's a mnemonic. There's a lot of different ways to recognize stroke, but there is a mnemonic that we like to talk to patients about. We call it Be Fast, which basically stands for a stroke is a sudden neurological problem.
The word stroke.
Yeah, it's essentially, basically, you've been stricken.
Right.
And, 1 minute you're normal, which is often what the family says to me, oh, he was normal a few minutes ago, and now he's like this. And the next minute he has a problem, or she. And it could be balanced, so that's the B. E for vision. If there's a sudden change in your vision, you lose vision, it could be a sign of a neurological problem. Face, you look at someone's face, we see them every day, family members see them every day. If one side is drooping, that's really a significant sign for stroke. It's very sensitive. Arm, if you hold your arm out and one of the arms are drooping, or you can't move the arm, or you can't move the leg, those are really important. So that's the arm and be fast. And speech. I'm speaking to you normally. I understand what you're saying to me. Those are the things that are important. If I suddenly start speaking gibberish, or if whatever you tell me I sort of ignore and I can't recognize, that's something called aphasia, and that's a sign of stroke. And the last T is for time. We always like to say time is brain. We got to get the patients evaluated and seen as quickly as possible.
And as you said, this is not an all or nothing phenomenon where you could have just some problems with slowness of speech, not finding the right word. That happens acutely. So that's that word stroke, stricken, anything that's acute. While I have you here, and I know your expertise goes beyond this part of it, I want to talk about hemorrhages. So people have bleeding in the brain, and about 20% of patients who have a stroke, a sudden onset of a neurological symptoms, will have some type of bleeding. And the bleeding could just be, as we sometimes think about plumbing, you have a choice. If you have a clogged pipe, it could either clog up, which is a stroke, ischemic stroke, or it could pop and cause a hemorrhage.
Yeah.
But you have a tremendous expertise in one kind of hemorrhage that I think is very important for people to know about. We've been seeing a lot of patients who've been getting MRIs, and we get MRIs for a lot of different reasons, headaches, dizziness, a number of things. And our technology has gotten so good that we're seeing a lot of patients with aneurysms, or they've had a family history of aneurysms, and they're very nervous about having aneurysms. Tell me about the new techniques that you guys have with treating aneurysms. The aneurysm treatment, I have a medical assistant who's still with us who had her head opened up and all kinds of things about 20 years ago, had this major surgery, and thank God she did well. But now, just even the idea that you think about doing open surgery for some of these, for something like an aneurysm, people look at you askew and say, no, we don't do that anymore. So maybe tell us a little bit about what you guys do.
I'd just say that our neurosurgery colleagues do open clipping, although it's much less frequent.
Okay.
Aneurysms are a significant part of the stroke process. I think 6% of patients have what we call subarachnoid hemorrhage, which is when the blood vessel starts leaking. And if you get the worst headache of your life, with trouble with the light bothering you, and the neck is really stiff and very painful, these are signs that you might have had an aneurysm, and those are definitely life-threatening issues. We all hear about patients who have had aneurysms and have unfortunately passed away. We go into the blood vessels in these things, and we find the area of weakness, which is like what we call the aneurysm, or the bulge on the artery where the blood is flowing in and it doesn't have a way to get out, so it's just putting pressure on the wall of the artery. And we have a lot of new devices. We can fill it with coils made out of platinum. We just, one by one, we fill it up until there's no longer any blood going into that segment. Or we have devices called the Webb device, which is a mesh that looks like a little balloon. It pops right in there and prevents the blood from going in there and stops it from bleeding again. The worst thing that can happen if you have one aneurysm that leaked is for another bleed. There's a 40% mortality, 40% death rate if you bleed again. So it's to identify it. Now, it's a different story if it hasn't bled. If you get an MRI and it shows an aneurysm.
Right.
But there are ways we can treat these things if we decide that it's appropriate to treat them, where you can come into the hospital, have the procedure, stay the night, and go home the next day. I've had patient after patient after patient say that none of their friends believe them when they say, oh, I had my aneurysm fixed, because they're looking for scars, for bandages, and it doesn't exist. And it's a world of difference where we can treat someone, send them home the next day, and at the end of the week, they're back at work and nobody knows that they actually had a major surgery on their brain, because we're doing it all minimally invasive.
That's absolutely amazing. If I think you gave a statistic. I think I'll put it in a little different way. Half the patients with aneurysmal bleeds, bleeding from an aneurysm, don't make it to the hospital.
Yeah. Yeah.
And so we don't even get a chance to help these people.
Right.
And in the old days, interestingly enough, patients who had aneurysms that bled, because it was such a big surgical procedure, usually were put in the back of the hospital, the intensive care unit, and in a dark room because they had very bad headaches, and hope that they did well for a week or two, and then they would do surgery. Right. Then they started doing surgery much earlier to prevent the problem, and now with these vascular approaches that we have, endovascular approaches, patients are doing them much faster, much quicker, much more aggressively, and it seems like patients are doing much better. So the idea of having an aneurysm, and maybe just back to just a couple of things maybe for education. You talk about small aneurysms, and I don't want to go over the details what small is, but most of the patients who are referred to for aneurysms, do you actually do the procedure or do you just more watch them?
Well, it really depends on a number of factors. We're still learning we're trying to identify who's going to get into trouble in the future. You know, if you see a very large aneurysm, you think of it as a balloon that you're blowing up, and if you blow up a balloon only part way, you know, you're not worried about it popping. But if you blow it up all the way to the end, you know, you see the kids, they go like this, you know, well, it's going to pop. So the larger the aneurysm is, the more likely we're going to go do an intervention. Smaller aneurysms, we like to sort of say, okay, we can watch this, especially if there's no history of bleeding. But, you know, we don't know everything. A lot of patients come to the hospital with bleeding and they have small aneurysms. So it becomes a choice and a discussion between the doctor and the patient about what they think is best for them.
So very interesting. So if I ask you, where do you think we're going with stroke care, aneurysm care? Again, you are in the most cutting edge portion. As a neurologist, we have multiple blood thinners that we're using. Yeah. And we're using stronger and stronger blood thinners for patients who have irregular heartbeats, people who have narrowing of the arteries, very similar to our cardiology colleagues using aspirin and usually another medicine. We call them dual or two antiplatelets or blood thinners together. Tell us where you think things are going.
I think we're going in the right direction. I think we've done the best way to prevent a stroke. The best way to treat a stroke is to prevent a stroke. And we have more powerful medications to prevent stroke. We have better treatments for the things that cause stroke, like atrial fibrillation. We now have Watchman devices. We have, you know, procedures that we can work on the heart to prevent atrial fibrillation from being an issue. We have better blood thinners. We treat diabetes more aggressively. There's always going to be patients who have stroke, and there's always going to be a role for someone like me doing that. But the truth is we can do a lot more benefit for patients in general by preventing them with medications. And
we're coming to the end of our time, and I just want to say, please get to the hospital if you're having a problem. The hospitals out here in Staten Island really are wonderful with regard to the treatment options that they have, and hopefully where you live, you have hospitals that are able to provide these kind of cutting-edge techniques. So please don't take them lightly. Treat your blood pressure, don't smoke, all the things that we talk about, and have a wonderful evening. Thank you.